Assalamu alaikum wa rahmatullah. In this lecture, I'll be talking about other causes of pain other than the ones that we've discussed in the TM joint and neuropathic pain. So this lecture will be divided into different parts, and I will be talking about vascular pain, neurovascular pain, psychologic conditions presented as pain, movement disorder, and miscellaneous conditions, particularly about auriculotemporal syndrome. So this busy chart shows classification of facial pain. So we've been talking about musculoskeletal pain here. We talked about TM joint and muscular problems. We talked also about neuropathic pain, both the episodic and continuous pain. In this lecture, we'll talk about neurovascular pain and vascular pain that is presented as arthritis in the vascular as example of a vascular pain, and different types of headaches as examples of neurovascular pain. We'll also talk about somatoform disorders, and as you can see, this belongs to axis 2, which is the psychologic conditions. So there are different psychologic conditions including mood disorders, anxiety disorders, but these are not actually presented as pain. However, there are different types called somatoform disorders where the pain complaint of the patient has underlying psychological conditions. So these are the topics we'll be talking about. Also, we'll talk about movement disorders that was not covered under any type of disorders. So we'll include it with the miscellaneous conditions. Okay, so starting with the first part, the vascular and neurovascular pain. So vascular pain, the example we'll be taking today is giant cell arteritis, specifically arteritis that affect the temporal artery, which is our area of concern. Arteritis is inflammation of the blood vessels of the endothelial cells, and it can affect any blood vessel, and particularly any blood vessel within the cranial area. But specifically, we'll talk about temporal arteritis, which affect the temporal artery. It is more common in females and in elderly patients beyond 50 years of age, and it starts as headache. So the patient complains of a headache in the temple area, so he might think that he's having, just a headache, maybe tension type headache, but with time it becomes more prominent. The artery, I think I have no, it's not here, I have an image. So the artery, the temporal artery would become more prominent. It might be presented as a TM joint problem because the patient will feel pain whenever he opens his mouth, and he feel that his jaw is tired, his muscles are tired, particularly after mastication process. So we call this claudication. So claudication means fatigue of the masticatory muscles after function. So all of these are signs of temporal arteritis, and usually it is associated with a condition known as polymyalgia rheumatica, where the patient complain of pain in shoulders and in the hip. It's found to be commonly associated or presented together. So when you examine the patient, you will notice the enlarged tender temporal artery. So this is the temporal artery. This area would be highly sensitive. Also, the patient might complain of allodynia, which means there's excessive sensitivity to a touch. Even pulling the hair in that area would be painful for that patient because it is highly sensitive. How can we confirm the diagnosis? You need to do tests including erythrocyte sedimentation rate and CRP. They are usually highly elevated. So again, ESR and CRP are not specific. They just indicate the presence of inflammation. And to confirm the diagnosis, we need to take a biopsy from the temporal artery. So when a patient comes to you complaining of a joint problem or headache, and you notice this prominent temporal arteritis or temporal artery, you notice that the area is really sensitive, it is worth referring the patient to a rheumatologist or orofacial specialist or even ENT doctor. They would be able to confirm the diagnosis by taking a biopsy from the temporal artery. And this condition is really important to recognize very early, because if it is not treated, this would lead to blindness caused by vasculitic changes within the eye, affecting the optic nerve and leading to a blindness. So it is important to diagnose this condition quickly and start treating it, and usually it is treated with prednisolone 80 milligram, which is a high dose. Taking a biopsy would show the presence of giant cells and inflammatory lymphocytes present in the endothelial cell, in the endothelium of the blood vessels. So this would confirm the diagnosis. So this is an example of vascular condition. In neurovascular, this is a specific type of or category of pain. In neurovascular, it means that it is affecting the blood vessels and the brain, mainly in the brain, and this is why we call it neurovascular. And the changes in the nerves or the excitation of the nerves would lead to vasodilation that eventually would cause headache. Headache, you know, we do not have let's say clinical tests or pathological changes that we can clinically see. It mainly depends on the description of the headache by the patients, and based on that, the International Headache Society set certain criteria or diagnostic criteria based on which we make a diagnosis of a migraine headache, for example, tension type headache, or a trigeminal autonomic cephalalgia, which is specific type of headaches that involves the autonomic nervous system and produce autonomic changes. And we will just have one example of the TAC, or trigeminal autonomic cephalalgia, which is cluster headache, which is the most common form of the TACs. So this image here shows the different types of headaches and different location of the headaches. So migraine headache, usually it is unilateral, affecting one side of the head. Tension type headache, usually it is bilateral. It is in this area, in the temporal area and the neck as well. Cluster headache, usually it is behind the eye. You know, this is like in a general description of the headaches. You don't need to go into details, just know the general descriptions. The sinus headache, which is a common headache, usually it affects the sinus areas and associated with other clinical signs of sinusitis. So starting with the tension type headache, which is the most common type of headaches, and you know, as the image shows here, it affects the temporal area and the neck. The patient would feel like there's a tightness or there's a band that surrounds his head. And it can be just episodic, which like it happens less than 15 days a month. And in some patients, they have a chronic type of tension type headache, and they have so frequent headaches, like more than 15 days a month, they would have that headache. These are the criteria, you know, for your information to know about. These are the criteria set by the International Headache Society to confirm the diagnosis of a tension type headache. So the patient should have headache between 30 minutes to 7 days. It is dull, aching, or pressing quality type of pain, mild to moderate. Usually it is bilateral. There is no nausea or vomiting associated with this type of headache. This headache can be precipitated by stress, anxiety, fatigue, or sometimes it is precipitated by myofascial pain in the masticatory or cervical muscles. Treatment, first we need to manage the stress, which is the underlying factor of tension type headache. Posture correction, because when the patient is not seated well, this would induce myofascial pain in the cervical muscles that would trigger a headache. How do we treat it? Well, if it is just episodic, you just take simple analgesics like acetaminophen or paracetamol or NSAIDs. They work very well for tension type headache. In some patients, when they have very frequent or chronic type of headache, we usually tend to avoid using the NSAIDs or the paracetamol because they cause a rebound type of headache. And this is true for all types of headaches. So if the patient is taking paracetamol or any simple analgesic like NSAIDs, if the patient is taking these analgesics frequently, they would have or they will develop a rebound headache. A phenomenon that is very similar when you are used to drinking coffee in the morning. That day where you did not have time to have your coffee, you will start having headache. So this is sort of a rebound headache because of the lowered caffeine level. And exactly the same when you have lowered level of acetaminophen or lowered level of NSAIDs, you will start developing headaches. So this is important to educate the patient and even for yourself not to rely on analgesics a lot so that you would not develop rebound headache. The second type of headache is migraine, which is also common but not as common as tension type headache, and it affects females more than males, particularly at the 30-40 years of age. And patients with migraine headache, they usually suffer from severe throbbing headache, and they cannot tolerate the light or sounds, and they cannot function as well while having the headache, so they tend to go and sleep or rest in a dark quiet room. There are different factors that precipitate headache in addition migraine. In addition to stress, hormonal disturbances induced by pregnancy or menstruation is a very common trigger for migraine. Any dental pain or muscle spasm or myofascial pain also might trigger migraine. Migraineurs usually, they must have sort of a stable lifestyle, a regular time of sleep, regular coffee intake. So any disturbances in their sleep or any disturbances in their coffee intake, this would trigger a migraine headache. Certain foods like cheese, for example, like other preservatives like the MSG, which acts as flavoring agents in processed food, also would trigger migraine headache. How does it happen? So it's a neurovascular problem. So the problem is initiated in the trigeminal nerve, and the trigeminal nerve is highly sensitized due to any triggers of excessive light, excessive smell, this would trigger and activate the neurovascular components, the nerves that supplies the blood vessels present in the meninges. After this stimulation, vasodilation would occur in response. Initially, they thought that the problem with migraine is the vasodilation. Then it turned out that vasodilation is a response to the nerves' high activity. So this is how it works. And once the blood vessels are dilated, there is lots of inflammation, let's say, in the brain, leading to a migraine headache. This slide shows the criteria stated by the International Headache Society, and we rely on this criteria to make a diagnosis of migraine. So the patient should have a migraine or a headache that lasts 4 to 3 days. Usually is the longest duration of a migraine headache. And the headache or the patient must have at least 2 criteria: unilateral pain, pulsatile in nature. This is in comparison to a pressing nature of tension type headache. Usually it is more severe than a tension type headache, so that it scales from moderate to severe pain and aggravated by physical activity. So when the patient like move his head or go upstairs, this would, increase the headache of the patient. One essential criteria is nausea and vomiting, which accompanies the pain. Photophobia and phonophobia, which means that the patient cannot tolerate light or sounds. And it can be with or without aura. Aura is the sensory, motor, or any or visual disturbances that the patient would feel or would have prior to headache. And with time, patients start to know that when he has this particular sensation, maybe a certain smell or certain visual disturbances, a headache would follow. So we call this a headache or a migraine with aura. Some patients do not have that aura. This is the features or characteristics we use to make a diagnosis of a migraine headache. There's a certain type of migraine which is not very common, which we call a mid-face migraine. In that migraine type, the patient will feel the throbbing pain in the face, and he might confuse it with dental pain. And so you need to be aware of mid-face migraine. How we treat migraine, it depends on the frequency. If it is just, it occurs like a couple of times in a year, or maybe one or maximum twice in a month, we call this episodic migraine headache, and we treat it with abortive medications, the medications that abort the migraine headache. Usually NSAIDs are very effective. For severe migraine, we use triptans, which are a serotonin receptor agonist. Works specifically for migraine headache. It's not analgesic. It is actually just act on the serotonin, which contribute to the pathophysiology of migraine. If the migraine headache is very frequent, like a patient having more than 15 times of migraine headache in a month, then abortive medication should not be used, and we use other medications that reduce the frequency of the headache. And usually the patient had to stay on that medication for a long time. Examples of prophylactic medication: beta blockers, tricyclic antidepressants, and Botox injections found to be effective in treating chronic migraine headache. They inject Botox at different sites in the forehead, in the temporalis muscle, the occipital muscles, and the trapezius. There's a specific locations for these injections, and the patient has to get these injections every 3 months to maintain the control of migraine headache. The third type of headache is the cluster headache. This is an example of trigeminal autonomic cephalalgias. In general, these types of headaches are rare. Cluster headache is the most common among the attacks, and it is the worst type of headache. It is the worst and the most severe form of a headache. Sometimes it is called suicidal headache because patients tend to think or have suicidal thoughts or even commit suicide because of the severity of the pain. It is more common in males, and it is called cluster because it tends to occur in a specific time, or the patient would have a cluster of headaches for about a couple of weeks, and then the headache would disappear for the rest of the year. So this is why we call it cluster headache. There is something peculiar about this type of headache, that the timing of the headache, either within the year, like it occurs at specific time of the year, usually autumn or spring, so at the time of the changing the season, and also the timing during the cluster period itself. So patients tend to have the headaches at specific times. Usually it's nocturnal headache, like in the night, and it happens every time at the same time, and this is why it is called alarm clock pain, because for example the patient might have the headache at 2 o'clock. If the patient went to sleep at 2 o'clock, at 2 a.m. the patient will wake up with headache, and this cycle would continue for the long or for the duration of the cluster period, for a couple of weeks. As we stated before, cluster headache usually occurs in the retroocular and the orbital area, and the females, sometimes the cluster headache might occur at different sites. Usually the upper jaw would be affected more. How it feels, it is, the patient would tell you that he's having like an excruciating pain, as if there is a, he received a stab in his eye, or like a burning or explosive pain in his eye, in the back of his eye, and it spreads also to the area like around the eye. It is unilateral pain, and it is associated with autonomic activity, so the patient would have conjunctival injections, which means redness of the conjunctiva, tearing, and also runny nose at the same site where he has the headache. It doesn't last long. It lasts about 15 to 3 hours, 15 minutes to 3 hours maximum. Most of the patients have, around 30 minutes or 45 minutes maximum. And as I said, it occurs usually at the same time of the day. And one important symptom is the restlessness and agitation. So in comparison to migraine, where the patient just want to sleep and get to a dark room, and in cluster headache the patient just keep banging his head to the wall, just stabbing or tapping on his eye and his head, just trying to relieve his pain. He's highly agitated and irritated. Right. What causes it? The pathophysiology of the cluster headache. All what you need to know is that the hypothalamus is involved because of the specific timing of the cluster headache, that it occurs or recurs at a specific or at regular times. Respiratory and vasomotor center would be involved because a patient with cluster headache would have relief from the headache if he receives oxygen administered through a mask. And this is considered one of the abortive treatment for cluster headache. Another treatment is triptans, again, the same medication used for migraine headache. They are also effective in cluster headache, but because of the short duration of the cluster headache, we tend to provide it not as tablets but as subcutaneous or inhalers, so the patient would have relief faster than tablets. Prophylactic medication used if the patient had chronic cluster headache, so some patients tend to have prolonged period of cluster headache, and for those patients they are given calcium channel blocker, verapamil, which found to be effective. The last type of headache is the chronic daily headache, and this could be just a transformed type of attention type headache, or migraine, or cluster headache. So the patient might have chronic type of any of these headaches: the tension, the migraine, the cluster headache. Sometimes the chronic daily headache is related to medication overuse, and we call it medication overuse headache. And for those patients, we need to detoxify the patient from the effect of medication and try to reduce the amount of medication that he is using, so that he will get rid of that headache. The last type of chronic daily headache is a new daily persistent headache, which means that all of a sudden patient started to develop a daily headache. For those patients, we need to refer for neurologists to rule out presence of any brain tumor or any abnormality centrally. And once this is ruled out, they usually receive different types of treatment, usually tricyclic antidepressants, or these types of treatment or medications that also would be helpful in controlling chronic daily headaches. So this is all regarding vascular and neurovascular headache. The next part we'll talk about psychological disorder. See you then.